Hi everyone, nice to see all of you. And let me thank Joanne. Thank you for, as usually, for help and organization of the meeting. And Donna, what a great honor to be here for your award. Let's get started with the first session of the day. I think I want to say to you that it's my great pleasure to chair this session. It's been years over years that I try to have a panel of faculty speaking about different type of transplant, because at the end of the day, it's not about cord blood. It's about the fact of where cord blood fits and the fact that every patient has a donor. So we need to understand what is the landscape out there for every alternative donor. So without spending more time, I would like to invite Shannon McCurdy from the University from UPenn, who's going to talk about haploidentical transplant. Thank you, Shannon.
All right, thanks very much. Going one at a time here. All right, haploidentical transplant, maybe not so alternative anymore. So, as we all know, to start off, the probability of an HLA-matched sibling transplant is about 30%. And so that leaves a large population of patients who don't have a perfect match sib. And the only options are alternative donors at that point. So alternative donors are really making up the majority of transplants. If you don't have a match sib, you could have a match unrelated donor, but that can be few and far between. An unrelated cord blood unit, or mismatch related family donor, or a mismatch unrelated donor. And I'll be talking about the mismatch family donors today. So the likelihood of finding a matched unrelated donor transplant is really ethnicity and ancestry dependent. So you can see that the likelihood here, Dr. Barker's sitting right there, who published this paper, of having a match unrelated donor 8 out of 8 transplant is much higher if you're of European descent, and very, very low if you're of African descent. So that's kind of where haploidentical donor transplant has come in. You only require one shared HLA haplotype to be a donor, and your parents are always going to be haplodonors, your children are always going to be haplodonors, and then siblings, uncles, aunts, nieces, nephews, cousins, grandchildren all have the potential to be haploidentical related donors. And so it really gives a wide donor pool from whom to choose. Now, in the original days when we were trying HLA haploidentical transplant, the GVHD prophylaxis that was utilized was methotrexate and calcineurin inhibitor based. And while this adequately prevents graft versus host disease in the HLA match setting, it is ineffective for GVHD prophylaxis in the HLA mismatch setting. So you can see here that the greater number of mismatches is associated with an increased probability of developing acute graft versus host disease. Methotrexate-based regimens are also less effective at preventing chronic graft versus host disease than some of our newer regimens. So, in the light of that, there began in 2001 the first murine studies of using post-transplant cyclophosphamide to allow engraftment of HLA-mismatched hematopoietic cells. And in 2008 was the first clinical trial publication by my mentor, Dr. Luznik, of using haploidentical transplant with post-transplant cyclophosphamide. After that time, post-transplant cyclophosphamide moved into the HLA match setting and also the mismatch unrelated donor setting, which Steve's going to talk about later. And then finally, most recently, it moved into HLA matched after a reduced intensity conditioning, where it has now become potentially standard of care. This shows that haploidentical transplant is really kind of exploding and taking off. Ever since 2008, and when that first publication came into place, there was a huge bump in transplants. And now haploidentical transplants, shown in green, occur more frequently than HLA-matched sibling donor transplants. And this is all due to kind of post-transplant cyclophosphamide. So in 2011, 59% of haploidentical transplants received post-transplant cyclophosphamide. And in 2021, 91% received PT-Cy-based prophylaxis. This means expanding access to transplant in the United States to people across all ethnicities. And so you can see that the, shown in green again, there's an increasing use of haploidentical in all races and ethnicities. However, it's much more prevalent in Hispanics, Asian Americans, and African Americans compared to white Americans because they don't have the match unrelated donor options. And so this has really afforded them a greater opportunity to go to transplant. It's not only affecting transplants in the United States, but haploidentical transplant with post-transplant cyclophosphamide has exploded across the world and allowed transplantation for some countries that don't have unrelated donor registries from whom to choose. So it's really increasing access to transplant. So today I'm going to talk about donor selection considerations, some drawbacks of haplotransplant, and then future directions. So let's begin with donor selection and the impact of HLA-match. So the probability of overall survival is very linked to HLA-match in unrelated donor transplant. And this was the article back from 2007 with Dr. Lee, who published showing that 8 out of 8 matched transplants had a 22% survival advantage to 6 out of 8 in early stage disease. However, you can see that the more advanced phase that the disease is, the less the positive impact of HLA match. And this hints to the fact that HLA-mismatch may be protective against relapse. Initially, haploidentical donor selection was inferred from HLA-match unrelated donor transplant, and there was a priority given for a higher degree of HLA-match. However, even in one of the earliest papers in haploidentical transplant in 2008, they examined the impact of 0 to 2 versus 3 to 4 antigen mismatch transplant and found no difference in acute GVHD, no difference in non-relapse mortality or relapse, and there was a trend towards improvement in event-free survival. In multivariable analysis, it was actually statistically significant as well. So even with the earliest papers, we see hints that at least mismatching greater numbers, not worse, but perhaps even protective. Subsequently, we collaborated with the CIBMTR and published a large analysis looking at the effects of number of HLA mismatches on outcomes. And 5 out of 10 match versus 7 out of 10 or higher did not affect any outcomes except relapse. And it was actually protective for relapse. So relapse was less in people with less well-matched transplants. We also felt that it might not be the number of mismatches as a whole, but the individual loci that have differing effects. And so as part of analysis, we looked at overall survival by different loci matched or mismatched. The first curve shows HLA-B leader, not B, but B leader match, and it was shown to improve overall survival. And this recapitulates data that we've seen from Dr. Petersdorf in unrelated donor setting. HLA-DRB1 mismatch, which is shown in the next curve, reduces relapse, and then HLA-DPB1 non-permissive mismatch also improves overall survival. HLA-C mismatch in this analysis was associated with chronic graft versus host disease. So as part of that, we developed a web-based tool for predicting disease-free survival after haplotransplant by different donors. You can input patient factors such as their disease stage, their HCTC-I, their age, and their CMV, serostatus, and then donor-specific factors for multiple donors. And you can see here that one donor versus another donor based on DPB1 matching, DRB1 matching, and CMV and B leader can give you a 29% difference in expected 3-year disease-free survival. So very many avenues for improving our donor selection in the years to come. So we've established that perhaps mismatching is better at class 2, but what else goes into donor selection? Is younger donors better? So again, we're going to start off with unrelated donor transplants, and this was the publication by Dr. Coleman in 2016 that showed there was a 5.5% increase in overall mortality for every 10-year increase in donor age. And so this really laid the foundation for our interest in using younger donors. And is that the case in haploidentical transplants too? This paper out of Hopkins demonstrated that there was an improvement in overall survival for donors age less than 30 across recipient ages. And this improvement was due to less non-relapse mortality with younger donors. So donor selection, age, maybe better younger. Does donor relationship matter as well? So this was another analysis with the CIBMTR where we looked at donor relationship, and we found that it did. So for patients who were younger, less than 55, we compared parent, sibling, and offspring donors and found that parent donors were associated with 17% incidence of graft failure, whereas a sibling donor with that younger age group only had 6%. So definitely a higher risk of graft failure using a parent donor. In this analysis, sibling versus offspring was not different in the older patient age group. Several other papers have also shown a worse association with parent donors and overall survival. Both the Discern analysis from Hopkins showed it in multivariable analysis, and also a paper out of the Georgia group showed an effect of parent donor having inferior overall survival. Another analysis also showed that perhaps parent donors were associated with higher relapse rate. So if younger donors are better and avoiding parents are better, what about choosing second or third degree relative haplo bone marrow transplants? So potentially, if you're choosing a grandchild versus an adult child who's 50, perhaps your outcomes could be better. And so this was the initial study that looked at the safety of using second or third degree relative haplos. And there were 33 patients enrolled. It's the same platform that's used in general for haplos, except in this analysis, sirolimus was swapped for tacrolimus. So survival outcomes were excellent. The 1-year overall survival was 95% using second or third degree relatives. And so a lot of physicians will use these interchangeably. So next in donor selection is one of the most critical factors. Do donor-specific antibodies impact outcomes? So what are DSA? DSA are antibodies against mismatched HLA antigens. They can be precipitated by fetal antigen escape during pregnancy is one of the most common mechanisms, but they can also be precipitated by cross-reaction of antibodies, prior infections, and transfusion history. Donor-specific antibodies worsen survival and increase graft failure after haploidentical transplant, and there have been many publications that have demonstrated this. There are strategies to mitigate DSA, such as antibody removal with plasmapheresis, antibody neutralization with clearance through IVIG. However, when the DSA are at very high levels of over 10,000 MFI, and sometimes with class 2 mismatch specific DSA, we're less effective at desensitizing patients. And so in those cases, we generally want to avoid the donor altogether, and usually we can find a mismatch unrelated donor to whom the patient has less DSA. So next we'll talk about drawbacks, real and imagined, and we'll start with some real ones. So one of the earliest clinical peculiarities of a transplant with haploidentical transplant was the recognition of an early fever that occurs from day 0 to administration of the cyclophosphamide on days 3 and 4. The fever is quite high, can be 104 degrees, and it occurred in 90% of patients receiving a peripheral blood stem cell graft and a myeloablative conditioning. It goes away after cyclophosphamide is administered, and it's not associated with infection, so cultures are negative. So we looked at this and found that the incidence is entirely related to the match. So in patients who have a matched sibling donor, early fever occurs in about 13%. In a match unrelated donor, 26%. In a non-myeloablative haplo, 47%, and a myeloablative haplo, 84%. And these fevers were also associated with mismatches specifically at class 2 loci. So mismatch in DRB1 and DPB1 were both associated with development of fever, and if you had mismatches in both of these loci, the fever risk was greater. Fever was not significantly associated with mismatches at class 1 or DQB1. So fever associated with haplo, also associated with myeloablation, and more frequent with class 2 mismatching. Another unique dilemma for HLA-mismatched transplants is that when relapse does occur, it can occur with a phenotype called HLA loss relapse. This was first published by Dr. Vago from Milan, who published this paper in 2009 and showed that 23% of relapse cases after haploidentical transplant had HLA loss, and this was in a methotrexate-based GVHD prophylaxis regimen. Mismatched unrelated donors can also have HLA loss relapse, and then matched unrelated donors can as well, but it's virtually absent in umbilical cord transplants. The curves or the figures to the right show the same data that we first published in patients receiving post-transplant cyclophosphamide. So it can happen with HLA mismatch transplant across the GVHD prophylaxis strategies. So why is it important to recognize this type of relapse? It's because donor lymphocyte infusion, which is one of our main ways to treat relapse, is virtually ineffective when you have an HLA loss relapse. Your strategy should probably focus more on either traditional chemotherapy to get patients back into remission, and then followed by a second allogeneic transplant using a donor mismatched for the retained HLA on the leukemia cells. Another method could be using novel therapies to re-engage the donor's immune system with the tumor and leukemia cells, such as DuoBodies, DARTs, etc. Now we'll talk about some imagined drawbacks. So let's go back to the beginning of post-transplant cyclophosphamide. This was the first paper, 2008, that published on the safety of haploidentical transplant. And what was really noticed was the fact that the non-relapse mortality was low in this paper, which much lower than historical numbers. However, what was also noticed was that the relapse rate was exceedingly high. This cohort of patients included a lot of patients with active leukemia and also with multiple myeloma, which doesn't really do well with transplant in general. And so this regimen kind of got the reputation of perchance being associated with higher relapse. So we wanted to kind of challenge this idea, and so we used risk-stratified outcomes using the disease risk index to analyze the outcomes with haploidentical transplant versus HLA-matched transplant. And we found that those who received a reduced intensity, either haplo or matched, who are low risk or intermediate risk disease, had equivalent outcomes. But actually, in the high and very high risk patients, there was a hint at improved outcomes in the haploidentical recipients. And this really is reminiscent of that work from Dr. Lee that shows mismatches may be protective, particularly for bad risk disease. There have been multiple subsequent papers showing that relapse may actually, in fact, be lower after haploidentical transplant. This shows some in acute leukemia, MDS, Hodgkin's lymphoma, non-Hodgkin's lymphoma, so really across disease type, but particularly strong for Hodgkin's lymphoma, there's been hints. So let's talk about some more drawbacks that are real. So even though I said relapse is not greater after haplo, relapse still represents the most common cause of death after a haploidentical transplant, shown at 50% of those who died beyond 100 days post-transplant died of relapse of their primary disease. The second most common is infection, and so those are really our two biggest areas of unmet need and we need to address to improve the outcomes of our transplant recipients. So how can we do so? So future directions. One area of possible future direction that we could explore is improving our natural killer cell recovery or using potentially natural killer cells to improve outcomes. So this was a paper that we published that looked at the survival of transplant recipients who received post-transplant cyclophosphamide based on their natural killer cell recovery at day 28. So if their counts were above 50, they had improvements in overall survival, progression-free survival, less relapse, and less non-relapse mortality. And that kind of represents the holy grail of transplant, something that reduces relapse and also reduces non-relapse mortality. Should definitely be something we would explore further. We did this in a CART analysis, and we also did a random forest that again showed us that natural killer cells were most impactful in overall survival after post-transplant cyclophosphamide. So given this, some other centers have looked at exploring NK cell adoptive transfer after transplant to reduce the relapse rate. And in this analysis, the 2-year relapse rate was remarkably low at 4% on this small study. And so we hope to see more of this in the future. Another potential avenue to reduce relapse and potentially infections is limiting the immunosuppression one gives after transplant. And so one avenue that right now is being actively investigated is looking at reducing the dose of cyclophosphamide. So cyclophosphamide is traditionally given at 50 mg per kg on days 3 and 4 after transplant, so a total of 100. And in this analysis, they dropped it from 50 to 40, so 40 times 2, so 80. And they focused in this part of it just in patients over 60. And so patients over 60 and definitely patients over 70 have worse outcomes relative to younger patients and tolerate high-intensity chemotherapy worse. And so their special interest was in improving outcomes for this population. They found that neutrophil recovery and platelet recovery were faster and more complete in patients receiving the lower dose of cyclophosphamide. There was also a numerical decrease in non-relapse mortality, but it was a small study and it did not reach statistical significance. So, in summary, donor selection for haplotransplant with post-transplant cyclophosphamide. Let's avoid DSA over 2,000 MFI. Let's use younger donors when available over older, avoid parent donors, choose a B-leader match if available, and then prioritize mismatching at DRB1 and DPB1. And future directions to reduce relapse could improve NK cell recovery, perhaps give NK cell adoptive therapy. Maybe we can limit immunosuppression, and I do have an ongoing trial of limiting the dose even further to a total of 50 mg per kg, 25 and 25, and so we're hoping that will also improve outcomes. And then we also need novel therapies to remove DSA, but in the absence of being able to remove the DSA, please pursue a mismatched unrelated donor, which my next colleague is going to talk about. And thank you guys all for your attention.
Shannon, thank you very much. It was a great talk. So we have time for a couple of questions. I forgot to say before that we are going to have a couple of questions now, and then the 3 speakers up here to the panel for also to get questions at the end of the session. Colleen, calling you out now.
Hello? Oh, there we go. So, I'm getting so old I need my notes. That was a fantastic talk. So thank you very much for being here. You're in a room full of believers of cord blood transplant. And that's actually where my question for you, and maybe I don't know if you guys have time for a panel after, maybe this can be addressed by everyone. You know, Filippo said this when he got up, that really the issue is about a donor for everyone. And as a transplant physician, I think, you know, I find myself at a center, and most of us do, where we either do haplo or we do cord. You had a fantastic slide in the beginning that said if you don't have a SIB, everything's alternative. Mm-hmm. So really, I have a sort of a thought-provoking question for you. How do you make the selection of your alternative donor, right? When we take into consideration, we absolutely agree with you. I think the data from cords, where we do mostly mismatched allogeneic transplants, are in line with what you saw with haplo, right? So I think we all agree that increased mismatching decreases relapse. But what about how do we really embrace that there's a donor for everyone? And how do we, as transplant physicians at centers, say, I've got a patient, what does a patient need? So do you guys consider things like non-malignant disease versus malignant disease, where non-malignant disease is generally harder to get a graft in, so you may say we want to do a haplo, Right, so I guess that my question is really around how are you doing this and how can we make this such that it's a donor for everyone? And okay, this is going to be highly controversial, and I'm sorry, and can we shut off the recording? But what about the fact that if you don't have a SIB, why are we not just doing haplo or cord? Like, why are we not bypassing a matched unrelated donor?
Yeah, that's controversial. So, I'm probably the worst person to be invited to this conference because it's been pitted against each other, right? Haplo and umbilical cord transplant for a long time, and it shouldn't be. And so I would say, I trained at a place that did not do umbilical cord transplants, but at my current institution, we do umbilical cord transplants, and we still use them today. So we're not one of the centers that's either or. We're using both, and we often use Juliet's regimen for the conditioning for our umbilical cords. So we're still using it. I would say where we use it most often, so one area is DSA. You can have DSA to cords too, but typically you can find a cord where the DSA is less than a haploidentical transplant because you get your DSA particularly to your related donors, and so the cord's unrelated, and so you're less likely to have DSA potentially to the cords, although you have to check that as well. So that might be one area where we would choose a cord. Filippo's data about the efficacy in decreasing relapse, particularly in AML patients. So a high-risk young AML patient could be another situation where you might choose a cord blood transplant as well. The situations I'm not using it as much is, benign diseases. So something you don't want a graft versus tumor effect in would definitely be something I'd shoot more. And aplastic anemia, you're more worried about infection, so a cord probably wouldn't be my choice there. So there are definitely scenarios where we use it. I would say my choice is generally haplo. It's my comfort field. That's my thing. Above a cord, if the DSA are at appropriate levels, but if not, then we'll go towards cord blood. There are patients who are adopted, right? And so they have no potential related donors, and so there it's always the choice between a cord and a mismatch unrelated donor. It's particularly if they're African American and don't have a match-related donor.
Great.
Juliet.
So we have time for 2 questions, Juliet and Joanne.
Hi, Sharon. A couple of things. Firstly, that was an outstanding talk. And in fact, I would say that you were one of the best people to be asked to speak at this session. And in fact, a lot of the things that you said is actually setting up what I'm going to talk about at 10:30. So congratulations. So I think the most important thing of what you said is that it's actually really complicated. And I commend you for going after everything you're going after, because it basically sets up the fact that there may be, we have to think about this concept of optimal donor, not just like I'm a haplo person, you're a cord person, now it's like, oh, haplo just went out the window because of the access trial for mismatched unrelated. So at Sloan in recent years, everything's on the table. Like everything. So every donor is on the table. I think that's actually critically important. But a few more comments about that at 10:30. But the other thing that I was going to say, and this is a comment about the field, is that we have just pulled out at Sloan data about just the demographics of the people that have HLA antibodies and the people that are highly sensitized or broadly sensitized. And the women that have had like 2 or more pregnancies, I mean, it's a real disaster.
It is.
And that's a problem for cords because we get cords in malignant patients with HLA antibodies, and even if there's DSA. But the problem for the cords, if you have class 1, then they're going to be platelet refractory for 35 days. That's a huge problem. So the HLA antibodies, I would argue, is a major problem for the cords, but for the platelets, not for rejection, if you sort of jig it so you can get the cord in. But I think it's a problem for the field that we haven't actually worked out how to desensitize patients correctly, and I think it's a problem because of the fact that the vast majority of the people that have this problem are women that have been pregnant. And that I think that says a lot.
I've actually submitted to several drug companies to try to get drugs for desensitization protocols, because I totally agree with you, it's a major thing. The emphasis now seems that most companies want to get approval in renal transplants, kidney transplants, and then if that gets approval, then maybe one day will trickle into our field, but that's their priority, is solid organ. And so I have not been successful with getting better desensitizations.
Neither will we.
Yeah, and so but definitely agree with you. I think that's a huge area, and I agree that cords, I don't think everyone recognizes the importance of analyzing DSA with cord blood transplants. And so I do think I've experienced it where a DSA has done what you said and had very refractory platelets, which prolongs the patient's hospital stay, can cause bleeding, et cetera. And so it's not a benign outcome.
And that's where mismatched unrelated PBSC might come into the mix.
Yeah, definitely.
And we're gonna have Steve talking soon about mismatched. Please, Joanne, 1 minute for questions.
I'm just going to go fast. First of all, thanks for a great and really balanced talk about haplo. I really appreciate that, so thank you. And you are very welcome here.
I was just kidding.
I'm also just going to say, and you don't need to answer me, we can talk about it later, but why aren't we using post-transplant Cy in cord blood transplant? So I want to discuss that in the panel.
Yeah. I have asked the same thing, and I think Juliet's asked the same thing too. A lot of us have. I think what the fear is engraftment, right? And so, techniques where we are having higher graft cell doses may be avenues where we can use post-transplant cyclophosphamide. The other issue may be once we get post-transplant cyclophosphamide at a lower dose, some of our engraftment issues will go away, and once the safety of that's been demonstrated, that could be very much utilized in cord blood. So kind of the same stuff I'm doing in haplo and mismatched and matched right now, where I'm reducing the dose of cyclophosphamide, might be an avenue for cords. And I agree, what I'm saying is better is PT-Cy, right? And that's the nuts and bolts of it, right? So why don't we use PT-Cy in everything, right? And then it might really change the outcomes with cords as well, and make the non-relapse mortality more akin to that of haplos.
And I think it's also to consider that PT-Cy might have a role for this expansion technology with cords, because engrafting becomes less of an issue. Shannon, really thank you so much for your talk. Please stay with me here on the panel. And I would like to invite now another outstanding speaker, Dr. Steve Spellman from the MDP and CIBMTR, and he's going to talk about mismatched unrelated transplant.
Thank you, Filippo, and grab that. All right. So I'm going to talk about mismatched unrelated donors. No disclosures, and here's my outline for today. So I'm going to talk about historical outcomes, which Dr. McCurdy has covered a bit with mismatched unrelated donors, so I'll kind of go through that pretty quickly, and then talk about the impact of novel GVHD prophylaxis and a focus on post-transplant Cy, and then some future directions. But first I want to start with some baselining. So this is data from the Center-Specific Outcome Analysis that's conducted by the CIBMTR every year. This is a HRSA deliverable that evaluates first allogeneic transplants performed within the US. It consists of roughly 26,000 transplants. And these are the odds ratios of donor and match level within the multivariate model that's used to evaluate one-year mortality. And so showing on the left-hand side HLA-identical siblings as your baseline. And what we see, again, these are odds ratios. These aren't absolute mortality levels, so please take that with a grain of salt. But this is the impact of donor type on overall survival at 1 year. Matched unrelated donors equivalent essentially to HLA-identical siblings in this model, but then as well as single cord 8 of 8 and single cord 7 of 8, also showing that favorable outcome, and no difference with a matched sibling donor. But when we look at the more alternative, maybe they're all alternative, as Dr. McCurdy was saying, but when we start to look at those alternative donors, we do see a step down and an increase in overall mortality early after transplant. Now, we do, even with the growth in worldwide registries with over 41 million donors available worldwide and over 800,000 cord blood banks, our cord blood units, we're still seeing about a third of all transplants are using these mismatched graft sources. Now, why is that? It's because of donor availability, 30% in the matched sibling donors, but then dropping to 29 to 79% based on NMDP modeling within the matched unrelated donors. And then when we look at single cords, we're seeing between 1 to 9% and 3 to 35% for an adult patient based on the HRSA modeling that's been done by the NMDP in the past. So how do we solve this problem? Well, potentially mismatched unrelated donors can fill that gap. This is data from a recent publication in JTCT from the CIBMTR bioinformatics research team led by Abu Chowdhury, showing that at 8 of 8 levels across the various ethnically diverse populations, there's a low likelihood of having a matched unrelated donor available. But when we move to a 7 of 8, a 6 of 8 level, you do have coverage for those patients. And this is taking into account donor availability at the time of request. And once we add in 5 of 8s, you really get to 100% donor or coverage for all patients in need. There's always going to be exceptions, but that's where we are. But the problem historically has been the outcomes. So with the use of a mismatched unrelated donor, we see a decrement in survival. We see increased rates of acute GVHD and other post-transplant complications. And from the Lee seminal paper that was published in 2007, showing that that's about a 10% decrease in overall survival. This has been validated in many other publications, mainly on a calcineurin inhibitor-based backbone for GVHD prophylaxis. So by Daniel First, published in Blood in a German cohort shown on the left, and then a large cohort that was evaluated by Joseph Padala, which built on that Lee population and extended into a more contemporary cohort, but still seeing that impact of HLA matching. Yes, it diminishes as disease progresses, and so that's why the messaging is to transplant as early in the disease process as possible with the best matched donor that you have, and that may be a mismatched donor. And how do we make those safer? Well, there's various strategies for using mismatched unrelated donors. These are some of the recommendations that came out of the NMDP IBMTR donor selection guidelines that was published in 2019, led by Jason Dean. One focusing on permissive mismatches, which I'll touch on a bit more, using younger donors, minimizing mismatching at lower expression loci, and then avoiding donor-specific antibodies, as has been shown in both the unrelated donor setting as well as in the haplo setting. And just to touch a bit more on permissive mismatching. This is an elusive thing that we had pursued for many years when I was leading the immunobiology working committee. One observation that we had that there was this one particular mismatch which was fairly common within the non-Hispanic white population. CO3030304 seems to be very well tolerated, and this is a consequence of where that amino acid difference between the two alleles happens to be. It doesn't impact the peptide binding domain. It also doesn't impact the T cell recognition domain of the molecule, and is very well tolerated. Building off of those principles, there's been various algorithms that have been developed over the years, looking at cross-reactive groups, old serologic strategies, HLA matchmaker, histocheck, supertype matching, perches, and recently peptide binding motifs. The problem is none have been a home run. None of these have really kind of identified mismatches based on just characteristics of those particular HLA and how there may be similarities that could lead to selection of an HLA that is better tolerated in this case. There is some distinction that can be made between individual mismatches, but none rising to the level of performing like a matched transplant like we see with CO3030304. So what else can be done? Well, pursuing alternative graft versus host disease prophylaxis strategies is another opportunity. And so, as Dr. Curdy mentioned, through all of the work that had been done at Hopkins over the years, there was a study that was conducted between 2011 and 2015, led by Yvette Casamon, looking at using mismatched unrelated donors down to, I believe it was a 5 of 8 level was the lowest match. That was used in this small cohort of 20 patients, using a non-myeloablative conditioning regimen and then a sirolimus containing PT-Cy strategy and bone marrow transplants. And what they showed was good engraftment, low rates of acute and chronic GVHD, and good overall survival and progression-free survival in this cohort. Now, building on this backbone, the NMDP launched a trial called the 15 MMUD study in 2015, looking at mismatched unrelated donors, considering bone marrow transplants using that same strategy, the same prophylaxis strategy that was used in the Casamon study from Hopkins, with a goal of achieving a 1-year overall survival of 65%, acute GVHD acute GVHD 3 to 4 of less than 15%, and engraftment over 90%. It met the goals, enrolling 40 patients on a reduced intensity conditioning arm, 40 patients on a myeloablative conditioning arm, with an overall survival rate of 76%, so quite a bit higher, but that also reflects improvements in haplo. It was benchmarked against haplo transplants at the time of inception of the trial. In the intervening years, outcomes have improved. And that's shown here in a real-world comparator data set where the trial patients were benchmarked against haplo-identical patients receiving a similar regimen, mainly a tacrolimus backbone on PT-Cy, using either bone marrow or peripheral blood, as well as some mismatched unrelated donors using peripheral blood that were reported to the registry in the time frame, not showing any difference in overall survival out to 1 year post-transplant. Acute GVHD rates, grade 3 to 4, were low on the trial as well at 11%, and engraftment was over 90%. This trial also enrolled 48% ethnic minorities, which is really high for a transplant trial, and really shows what this platform is really serving. Now, looking at the overall impact of match in this population, granted it's a small population, this is 80 patients total, but roughly 40% received a multiply mismatched transplant, so less than a 7 of 8, and we did not see any difference out to 3 years in overall survival between those two groups. And so most received a 7 of 8, with 32% receiving a 6 of 8 and a small percent receiving 5 of 8 on trial. There was also no impact of DPB1 match status on this, as was observed in the Fuchs study that Dr. McCurdy showed, but again, small numbers. So need to build up that population to be able to evaluate that with more power. Now, that was all using bone marrow. At the same time, there was a single center study that was conducted at the City of Hope, led by Dr. Mansour al-Maliki, and showing that using peripheral blood stem cell grafts and a tacrolimus PT-Cy backbone, outcomes were quite good, using minimally mismatched unrelated donors, and this was mainly 9 of 10 matched transplants. So where do we go from here? Well, the NMDP has opened the ACCESS trial, which is continues to accrue on 2 strata at the moment. But this is using, again, mismatched unrelated donors down to a 4 of 8 level, shifting to a tacrolimus PT-Cy backbone, and using peripheral blood stem cell grafts. Because PBSC is used by over 80% of adult transplants today. So the timeline here was the first patient was enrolled in 2021, initially projected to complete accrual by July of 2023. It enrolled quite quickly, closing Stratum 1 in February of this year, and Stratum 2, the initial 90 or 70 patients, by September of last year. Because of the rapid accrual on the reduced intensity conditioning arm, we expanded that population to add another 100 patients, mainly to be able to look at effects of level of HLA match and particular impact of individual loci to kind of build up that body of evidence. So that continues to accrue at this point. We do hope to be able to report some results on this early in 2024 for the initial strata. Now, this has really kind of taken off. So the use of PT-Cy has continued to expand within the mismatched unrelated donor space. As Dr. McCurdy mentioned, today we see about 90% of all haplos, or over 90% of all haplos using PT-Cy. We're up to, 64% in 2021 using mismatched unrelated donors. Expect that to be, say, 75, maybe even 80% in the currently. Now, where is this going? What have we seen from a trend in mismatched unrelated donor use within the National Marrow Donor Program? Well, this is looking at transplants that have been facilitated, looking at 2018 through 2022. When we consider, since the 15 MMUD paper was published, and benchmarking across that, what we've seen is a 19% increase in the use of 7 of 8 matched donors and an 85% growth in the less than 7 of 8, although those less than 7 of 8 numbers still remain quite low, as you can see from the figure. And again, showing the breakdown of the patients that are receiving these transplants, it's approximately 47% are ethnic minorities. So really filling that need for that group because the matched unrelated donors aren't there. So use of mismatched donors can eliminate availability gap and expand donor choice. So this is additional modeling that was included in that recent publication that was led by Dr. Chowdhury, showing on the left-hand side, considering younger donors, which have been associated with better transplant outcomes, that we still see essentially universal coverage down to a 5 of 8 level. And with donors less than 35, and then layering on other criteria, in this case on the right-hand side, considering a DPB1 TCE match, we also see similar levels of coverage with some with additional 5 of 8s having to be included here to get to that full 100%. And this is quite a lot of choice. And to illustrate that, this is some additional data that was included in that same manuscript, looking at recent searches of the NMDP registry that requested a mismatched unrelated donor search. So to include donors down to a 4 of 8 level because the patients were very unlikely to have a fully matched unrelated donor available. And in this case, so of these nearly 900 searches that were run in a 2-year period, considering just donors under the age of 35, when we look at 7 of 8 match, the median number of donors that would be available is 9. When you go to a 6 of 8 level, it's 330, and when you go to a 5 of 8 level, it's over 6,000 donors. So spoiled for choice in some of these in this setting. But we need to understand how to optimize the selection. And Dr. McCurdy showed some of those results from the from the haplo-identical modeling that was conducted through the Immunobiology Working Committee and published by Dr. Fuchs in Blood in 2021, showing that there may be opportunities to optimize the selection of those donors. So whether that's a B-leader match, or an HLA-DR GVH mismatch to enhance relapse and disease-free survival, or considering HLA-DPB1, and in this case, mismatches as opposed to permissive matches or permissive matches, and considering HLA-C. And so being a bit more selective, but we need to have more data to be able to start to analyze this. There's various observational studies that are being conducted through the Immunobiology Working Committee of the CIBMTR that'll be exploring these concepts in the mismatched unrelated donor PT-Cy population in the coming year. So how do these mismatched unrelated donors compare to haploidentical related? Well, there's limited data that's been shown to date. There are some comparative analyses that are underway. But in a small cohort that was published by the EBMT in 2022, showing that 9 of 10 using a mismatched unrelated donor on a PT-Cy backbone compared to haplo bone marrow peripheral blood did have better survival. And there are, with the larger donor pool that's available, there's that opportunity, sorry about that, to be more selective in your HLA mismatch selection, and also considering other non-HLA factors. So younger age, CMV status, ABO, sex match, and donor-specific antibodies, being able to avoid those with that broader donor pool where you may not have that opportunity within a smaller family group, even looking at an extended family. Some recent data from the Blood and Marrow Transplant Clinical Trials Network that was presented at EBMT earlier this year from the Control-Alt-Delete or clinical transplant-related long-term outcomes of alternative donor allotransplant. This was a secondary objective analysis that was completed. The primary objective is still pending time, so waiting for to be able to do the comparison between alternative donors. But this was using a specific algorithm to determine the course of treatment for a given patient based on their search prognosis at the time of enrollment. And so effort was led by Jason Dean and Joseph Padala and reported at EBMT on the incidence of receiving transplant per search prognosis and characterized the search selection decision making that was used. I'll note those two in the talk. And so this was a biologic assignment trial with intention to treat. So using a search prognosis score that was developed by the NMDP and published back by Kim Wadsworth and published back in, I believe it was 2015, based on the frequency of the HLA of an individual. So they're stratified based on being very likely to have a matched unrelated donor available, less likely to have a matched unrelated donor available, or very unlikely to have a matched unrelated donor available. The study focused on just the very likely and the very unlikely groups. So, and prescribed a treatment strategy. So these were patients that the center had declared needed to proceed to transplant within the next 6 months, and so they were going to follow this algorithm and use their preferred alternative donor declared at the time of enrollment. So expected to see approximately 90% matched unrelated donors in the very likely arm and less so in the very unlikely, and enrolled over 1,700 patients, 93% in the very likely group proceeding to transplant with a matched unrelated donor, and 89% in the very unlikely group proceeding with an alternative donor. An important takeaway is that having a donor available for everybody allows you to move forward with transplant on an appropriate timeline. And so looking at intent to transplant by 6 months, there was no difference in the rate of transplant between the very likely and very unlikely. So rapidly transitioning to an alternative donor when there's no likelihood of having a matched unrelated donor or extremely low likelihood of having a matched unrelated donor is the appropriate strategy. Now, we're still waiting for the outcomes to mature there, but I don't think there's going to be that much of a difference between these groups at the end of the day, and you can hold me to that when the results come out, but we'll see where that ends up. Now, looking at trends in first preferred donor over time, that did change over the course of the study. And maybe this is because of the publication of some of the data on mismatched unrelated donor, or maybe it reflects just changes in practice at the individual centers. But we did see an uptick in the interest in using mismatched unrelated donors in this case. Maybe that's a large, highly sensitized population and moving in that direction, but that remains to be seen. So with that, just to kind of close, with alternative donors, we really eliminate the donor availability gap. And here again, I'm showing the likelihood of having a matched unrelated donor on the registry, ready to go and able to proceed at the time of search. 29% to 79%, but when we consider haplo sources, mismatched unrelated donor sources, or cord blood sources, having a match for essentially everybody. There's always going to be outliers. Filippo was sharing a nice anecdote right before this about a patient that just had no unrelated donors, but had cords available and just needing to get the center interested in actually performing that transplant. So with that, I'll just conclude that HLA-mismatched donors options really expand that access to transplant. Eliminating the donor availability gap allows you to kind of rapidly select the donor that's needed at the time. And there isn't as much of a trade-off as there used to be, thanks to these new novel GVHD prophylaxis strategies, as was seen historically. PT size really driving these improvements in outcome, at least at the moment, but there's room for improvement on that platform. Dr. McCurdy mentioned reduced dose PT Psi. The NMDP is sponsoring another trial called Optimize, which is building off the Access platform and looking at reduced intensity, reduced PT Psi dosing, going down to a 25 milligram from a 50 milligram per dose to a total of 50 milligram. PT Psi, and that will be opening later this fall. But there's still ways to improve on this, whether that's adding additional agents such as abatacept or others to further reduce acute GVHD risk and chronic GVHD risk remains to be seen, and there are some small studies that are kind of underway evaluating that. But these GVHD prophylaxis paradigms really drive an opportunity to optimize for other factors, so HLA and non-HLA factors, and really optimize those donor characteristics. And the BMT CTN 1702 study to me, clearly demonstrates that mismatched unrelated donors and other alternative donor sources can support equitable access to transplant as a curative therapy. And so with that, I'll just acknowledge the teams that I work with at NMDP and CIBMTR, and I'd be happy to take a few questions. Thanks.
Another outstanding talk, Steve. Thank you so much for this talk. We have a couple of questions that can be asked. I want to start saying that I've been a transplant doctor, believe it or not, for over 20 years now, and I think there has been very few things other than like PT side that have changed the field like it does, both for haplo and mismatched only. I'm not going to ask questions. We have people there. Colleen, start.
Hello. I forgot to ask this last time, but it's still relevant. This is just a prospective question. Now that we're seeing so much more PT-Psy and we have such good ways of evaluating donor-derived leukemias post-transplant, do you think we're going to see a rise in donor-derived leukemias based on the increased use of PT-Psy? And I assume we're going to be following this.
That's a great question. We are following it, or at least we're attempting to do that through the registry, so we'll continue to monitor that and differences that are seen. But as of right now, there just doesn't seem to be an acute rise in donor-derived leukemia due to increased use of PT-Psy. So no huge red flags at this point, but definitely something that needs to be taken into account. And it'll be considered. So,
Karen, please.
Hi, Karen Ballin from University of Virginia. Thank you, Steve and Shannon, for some great talks. So we've almost gone to the situation for many patients where maybe we don't have enough donors to where we have so many donors. And sometimes it's hard to know what to choose. Now that the NMDP is no longer Be the Match, it's NMDP, is it possible that the NMDP could help the transplant centers with some algorithms to help choose the best donor for the patient, whether it's an unrelated donor, a related donor, mismatched or not, or cord?
That's a great question, Karen. And yes, that's an active area of inquiry within the NMDP and the CIBMTR. So looking at various machine learning or AI opportunities to kind of look at what is the appropriate donor landscape and how donors should be prioritized in particular settings. But that's a work in progress at this point. And with PT-Psy, the experience within Haplo, yes, we have a decade's worth or more of experience at this point, but we're really kind of in the infancy as far as matched unrelated donors, matched sibling donors, and mismatched unrelated donors in that setting, with opportunities potentially within cord as well. So we'll need to continually update those algorithms to really better understand where things are going into the future. But yes, something that we definitely want to put into play.
Great, thank you.
So we have time for another question. I'm going to ask this question because really I want to know. So I meet my patient tomorrow in clinic, and it's about for you, the two of you. And I need to tell this patient that I can go either with a mismatched unrelated with a haplo donor. What is going to be the rate of chronic GVHD, moderate and severe, that I need to expect using these two different stem cell sources? What will make me be fair to call for this patient?
Moderate to severe chronic GVHD with a haplo bone marrow or peripheral blood?
Both.
So, I mean, with a bone marrow, it's probably like 12%, 10%. With a peripheral blood, probably double that.
Mismatched unrelated.
Well, we're seeing it about the same at this point, but remains to be seen. So we'll get more data from the ACCESS trial. But one thing from the 15 MMUD, it was a rate of, I believe it was below 15% overall for moderate to severe, and there was no increase after a year of follow-up. So it was all within the first year post-transplant as well.
I would say, the vast majority of chronic GVHD we see is just ocular and oral, We do not get the degree of sclerodermatous GVHD or pulmonary GVHD that methotrexate intact does.
Yeah.
That stuff goes away. It's just your eyes are really can be irritated in your mouth.
Yeah, and it's interesting too because with cord Fred Hutch, we have about 7%, so it's very low rate of chronic GVHD, but we don't use PT-Cy. So definitely some intrinsic property of cord blood cells that don't need some other GVHD prophylaxis to have the same chronic GVHD rate. Thank you so much, Steve. And let's move to the last talk of the day. Dr. Leland Metheny, please take us to understand where cord blood can fit in this landscape. I don't think you need an introduction, but please go ahead.
So thank you to Filippo for inviting me to talk. This is one of my favorite conferences along with Tandem, so it's a personal honor. So I'm going to be talking about the landscape of cord blood transplant, and I'm going to begin with that, and there's going to be themes that I go through about the different landscapes that we could see depending on what we look at. So, and this is an artistic bent. So it's a little bit different than the other. So in a landscape painting, you want to ask, where are we and where am I, as you look at it? And so as a cord blood community, where are we? Are we in Dante's Hell, which is on the right? It's a circular or conal picture. And are we descending into the abyss? Or are we on the precipice of a new and exciting time, like the painting of the Plains of Heaven by John Martin? So let's begin with the good first. What do we see if we're in cord blood heaven as a landscape? So we see continued optimization of cord blood transplant, comparing the outcomes between 2001 and 2005 to 2016 to 2021. The 3-year overall survival for single cord blood transplant has improved from 41% to 64%. Comparing the same periods, the 3-year overall survival for double cord blood transplant has improved from 34% to 53%. This increase in overall survival is a relative improvement of over 50% for both single and double cord blood transplants. Similar improvements of clinical outcomes over time have been shown in pediatric-specific analyses by Kurtzberg and colleagues in a recent publication. These improvements signal that the optimization of cord blood transplant continues to the present time and has resulted in significant benefit for patients. We see a robust graft versus leukemia or disease effect from cord blood transplant. In a retrospective analysis by Filippo and colleagues, patients who underwent cord blood transplant, the majority of them double, experienced less relapse when compared to HLA-mismatched or HLA-matched graft sources when the patient had minimal residual disease before transplant. Additionally, while minimal residual disease was a factor that increased relapse risk and overall mortality in patients who underwent transplant with HLA-mismatched or HLA-matched graft sources, it was not a factor that increased those risks in patients who underwent cord blood transplant. And we see the advent of expanded graft sources in cord blood transplant. Amadubicel, a cell product derived from cord blood, which consists of a CD133 positive fraction that is ex vivo expanded, utilizing a nicotinamide-containing culture system, and an unexpanded CD133 fraction, has been shown in a randomized phase 3 study led by Dr. Horowitz out of Duke to have faster median time to neutrophil engraftment compared to cord blood controls, with the primary outcome of neutrophil engraftment being 12 versus 22 days in the figure to the right or left. These patients treated with amadubicel also had less bacterial and fungal infections. Clinical outcomes such as disease-free survival and overall survival and chronic graft versus host disease were similar between the groups. This advancement sets the stage for expanded access to allogeneic transplant for patients without an HLA-matched donor. But what do we see in cord blood hell? We see a substantial decline in the use of cord blood graft source in all ethnic and racial groups, from a peak of over 500 cord blood units for single cord blood transplants in 2013, which is down to a little over 300 in 2022. For double cord, the drop has been more drastic, with the decline from around 500 to just over 150 in 2022. The results of the BMT-CTN 1101 trial, which was two parallel phase 2 studies of patients with hematologic malignancies, compared those undergoing cord blood transplant to those undergoing haploidentical transplant utilizing a non-myeloablative conditioning regimen. While the primary endpoint of 2-year progression-free survival was not significantly different between the groups, the figure here is the visual abstract in the publication and is a secondary endpoint of overall survival, which was significantly different between the groups favoring haploidentical graft sources and driven by high non-relapse mortality in the cord blood group. While there have been many critiques of the study ranging from an inferior conditioning regimen for cord blood to imperfect graft selection, these critiques in the face of in a prospective clinical trial seem sour grapes to many. In addition to the results of the BMT-CTN 1101, some, but not all, retrospective analyses from the CIBMTR and the EBMT have suggested inferior results with cord blood. For example, in an analysis comparing clinical outcomes for recipients of haploidentical transplants for the treatment of acute lymphoblastic leukemia, cord blood was found to have similar overall survival, but a greater early mortality, which was before 18 months. It should be noted that this early mortality survival analysis was It should be noted that an early overall survival analysis was only performed and published between the haploidentical and cord blood group, not other graft sources, and it was not mentioned as a primary or secondary outcome. In another analysis, with the goal of understanding the impact of body mass index on clinical outcomes with different graft sources, it was suggested that there was a significant difference in PFS when comparing cord blood transplant to other graft sources at certain BMIs. However, a deeper reading of the manuscript revealed that if double cord transplants were only included in the analysis, those differences disappeared. Perhaps we need to change the question that we are asking and view where we are a little bit differently. I am convinced that if we distill the value, purpose, and usefulness of any graft source, and cord blood included, to something as limited as a transplant outcome, we will continue to do a disservice to our patients and research. While comparisons are prudent and necessary, the primary goal of cord blood transplant can't be to beat haploidentical or mismatched graft sources or be the best in a retrospective or prospective analysis. That's zero-sum and it's myopic, and some would argue limits our practice and innovation. But if we shift our collective focus to the question of how we can make cord blood or any graft source the best it can possibly be in the appropriate patient for the appropriate transplant and cellular source, we are getting to the right question. So how can we do that? The first step is quality improvement. We have a problem in cord blood transplant that is not unique to cord blood transplant in terms of kind, but in terms of magnitude, we may be quite alone. We have published society guidelines that are endorsed by ASTCT and the NMDP in cord blood transplant, and for the vast majority of cord blood transplants, these guidelines are not followed. With only using two criteria, which are cell dose guidelines, that's CD34 and TNC doses minimum, to characterize those transplants that followed or did not follow the guidelines, we see that roughly 60% of double cord blood transplants did not follow dosing guidelines. If we look specifically at single cord blood transplants, roughly 49% do not follow guidelines based on cell dose. Friends, we do ourselves a disservice to our patients and cannot do research properly if we cannot perform high-quality cord blood transplants that adhere to guidelines. And while these guidelines are recently published, representing a comprehensive set of practice-specific criteria and recommendations. The data from which they draw is not new. As early as 2002, it was recognized that a CD34 dose of 1.7 times 10 to the fifth cells per kilogram differentiated between cord blood recipients surviving better and those that survived worse. At the same time, we have examples of expertise within our field, and this expertise is expressed with excellent overall survival, progression-free survival, and graft versus host disease relapse-free survival outcomes following cord blood transplants. These publications are recent, and they are evidence of continued optimization of cord blood transplant that I spoke of earlier. In the top right, we have outcomes from Barker and colleagues, retrospective analysis of double cord blood transplant with or without a haploid myeloid bridge, proceeding with the flu-cy-thiotepa TBI mini prep regimen for patients with acute leukemia and MDS, which demonstrated a 3-year progression-free survival of 76%. In the top left, we have Milano and colleagues' prospective trial utilizing the treosulfan-based conditioning regimen for cord blood transplant, demonstrating a 3-year relapse-free survival of 57%. And it should be noted that this study included a significant proportion of patients that had a previous allogeneic transplant. In the bottom right, we have outcomes from pediatric patients out of Texas with non-malignant disorders undergoing a prospective clinical trial with cord blood transplant utilizing a MAC conditioning regimen without ATG, with a 2-year overall survival of 91%. And finally, we have our colleagues in Colorado who compared cord blood to an HLA-matched sibling donor and demonstrated superior graft versus host disease relapse-free survival with cord blood. So how can we close the gap between the lack of quality and yet the clear evidence of expertise we have in our field? It may be that the diffusion of knowledge and skills beyond centers of excellence is needed. In addition, societies and organizations such as ASTCT and the NMDP that facilitate cell therapy should assist clinicians in selecting the appropriate graft sources, or at least the cell doses, and providing resources for education and opportunities for skilled development. We have already taken the first steps in publishing the guidelines, and the NMDP is supporting an immersion and mentoring program in cord blood transplant to ensure that the next generation of cell therapy clinicians can have the skills to utilize cord blood effectively. Quality initiatives from the NMDP and cord blood experts in this community should be developed to reach the highest quality cord blood transplant and cellular therapy possible. This needs to be proactive and not reactive, and it cannot be passive. Finally, quality practice will form the foundation for cutting-edge, effective, and exciting research, building upon standardized protocols and practices that are proven to be safe and effective. And what will this research look like? It doesn't take much foresight to see that the future belongs to optimized and manipulated cell sources, such as CAR-NKs and NK cells. These products and platforms allow for greater access of cell therapy to all patients through the form of expansion, off-the-shelf products, and in patients who have high-risk disease for which standard of practice is not effective. It will provide greater effectivity for high-risk disease, such as graft versus leukemia optimization, and wider application for different disease types utilizing CAR-NK and complex cord blood NK cells for diseases such as myeloma and solid tumors. On the top right are the clinical outcomes of 22 patients undergoing transplant with the UM171 product from Cohen and colleagues out of Canada, where 23% had a previous allogeneic transplant. This product can be rapidly manufactured in 7 days, and it results in a 28-fold expansion of CD34 cell number. The median neutrophil and platelet engraftment were 9 and 42 days, respectively, and a PFS at 1 year of 74%. At the top left is CD8 expansion kinetics from the publication out of England from Dr. Wynn's group, detailing the observation of a more than robust expansion of cord blood CD8 T cells in pediatric patients with refractory leukemia, one patient that had 90% blasts in their blood and marrow. After an infusion of unmatched granulocytes for infection following cord blood transplant. Surprisingly, the 5 patients that were observed with refractory leukemia remain in remission after 1 year. In the bottom left, we have the horizontal waterfall plot of 11 patients who underwent unmatched cord blood-derived CD19 CAR NK cells for lymphoma with an overall response rate of 73% and a CR rate of 63% without evidence of significant adverse events that are common for CAR T cells, such as CRS and neurotoxicity. Additionally, future allogeneic CAR NK cells have the advantage of not being exposed to previous DNA-damaging chemotherapy and immunotherapy, unlike autologous CAR T cells. Lastly, in the lower right corner, we have a preclinical experiment by Ortiz and colleagues out of Spain demonstrating superior cytotoxicity against patient multiple myeloma samples compared to healthy donor peripheral blood NK cells, irrespective of the addition of anti-myeloma therapy. Additionally, there are at least 12 open clinical trials investigating cord blood NK cells on clinicaltrials.gov. And with these NK cell products, we see the potential for effective delivery of manipulated, unmanipulated, and complex NK cells with or without transplant. Imagine autologous transplant for myeloma followed by maintenance Revlimid, along with monthly infusion of cord blood NK cells for perhaps eradication of disease. So for a successful future, we must strive for the adherence to guidelines and delivery of cord blood transplant for cellular therapy to our patients. This will assist in the continued optimization of cord blood-based cell therapies and allow for more platforms to enhance GVL and improve engraftment kinetics and immune reconstitution. Off-the-shelf cord blood products, including natural killer cells, NK CARs, complex NKs, cord blood Tregs, cord blood MSCs, and cord blood multipotent stem cells, will find their niches in malignancy, autoimmune diseases, and regenerative medicine. We must continue to look for conditioning regimens that minimize toxicity and improve efficacy in cord blood, especially for an aging population, and this might include radioisotope-based conditioning. Additionally, we need to eliminate grade 3 to 4 acute graft versus host disease from cord blood transplant as a driver of non-relapse mortality, and we need to borrow from our mismatched unrelated donor and haplo colleagues with the utilization of either abatacept or lower dose post-transplant cyclophosphamide. Lastly, cord blood and cord blood cell therapies will expand access to ethnic, racial, and underserved populations that have far too long suffered from lack of access to life-saving therapies. And if you will indulge me, I'll wax poetic for just 1 minute and offer some thoughts that came to mind as I was preparing this presentation. The first is that graft sources are not an end to themselves. And of course, this is obvious, but it should be said that the purpose of any graft source is to not further the utilization of that said graft source. Whatever the graft source, it is a tool to cure disease. Just as a carpenter utilizes a hammer and sometimes uses a lathe and at other times uses both, he has to use them with skill and expertise. So should every transplant center and our transplant teams have the open-mindedness to utilize graft sources with skill and expertise. A tribal mentality benefits no one, least of all our patients. And I hope that we can start to change the valuation of competition and put forth first innovation and collaboration. Competition is good, but collaboration and innovation are better. And lastly, I cannot stress this enough, quality is the basis of all successful products and practices. We need to take quality seriously in our practice and in our societies within the cord blood community, and I recommend rigorous and evidence-based practices to be developed among our colleagues. So perhaps we find ourselves here. This is the mountain of purgatory. It's an allegory of self-improvement. And I love this quote from T.S. Eliot that, we don't cease our exploring, but we'll find ourselves in the place we started and know it for the first time. So thank you so much.
Great talk, Leland. You reminded me that in Italy we are forced to study Dante and Divine Comedy in high school. And believe me, there are three. It's hell, purgatory, and heaven. And there are 33 chants. So it's very long. So I don't know if we have questions in the audience yet. I think we do have 10 minutes to end the session. I'll start with the...
Do you want me to sit down?
Actually, you can come here. Yes, come with us. Yeah. I'll ask you the question to you, Leland, and then we'll move to the other speakers as well. So why do you think we are seeing such discrepancy? And I know that we have not analyzed the data. Steve is the chair of the graft manipulation committee. The data have not been analyzed yet, but what do you think there's not been agreement in using what has been proposed by the cord blood guidelines? What will come to your mind? I know that we don't have the answer yet, but what is your speculation? Yeah.
Oh. It's probably a little bit of prejudice. I think people were, I think they find haploidentical transplant to be somewhat easier in terms of practice, and they don't want to relearn the skill of doing a cord blood transplant. That's my thought, but take it for what it is.
And I'm going to give you the question right away, but prejudice, this is actually over a long period of time. So who was selecting the cord blood units was not doing a good job even before the rise of a haplo. So prejudice explains, but I don't think it explains it all.
No.
And it's something that we need to educate people. If you want to do cord blood transplants, you need it properly, choose a good unit.
And that's how the NMDP can really help transplanters in identifying cord blood units that fit guidelines and not allowing a inappropriate cord blood unit to be chosen for a transplant.
Just increased education too. I mean,
Yeah,
I think
exactly.
people don't know what to do.
Exactly.
They don't know the rules.
Absolutely right.
And many of those gates are in place, and those recommendations are made by our search strategy team, adhering to those guidelines. So that is part of the recommendations that are given. Centers may choose to prioritize based on other criteria, whether that's HLA-match or other characteristics.
I agree with all of you. So now we have 3 questions in the audience. Please tell your name and refer to question to one of our panelists.
Hi, I'm Doug Gladstone, and I have 2 questions. The first is actually for the first 2 speakers. We spoke about donor-specific antibodies, but there is a big difference between the solid phase, the Luminex platform, and flow analysis, and the interpretation of mean fluorescence, I think, is complicated. So, I mean, the HLA-C will have a different brightness than against others. So when there's a discussion about donor-specific antibodies at your institutions, are you using flow, just the Luminex platform? And then the second was unrelated, but in choosing donor, again, grafts, in the priority list, are we also now considering like DDX41 or congenital illnesses that we're worried about transplanting the child to the parent as we go to the younger donor? Thank you.
Hi, Doug. Your paper is often the one we cite on DSA, so you probably know the answer better than me. But we use Luminex, and I know some other centers use flow positivity as their criteria. It just increases the complexity of the DSA and why it's not easy to transfer strategies from one center to another. And so, I agree, we use Luminex, but that varies from center to center, and you're right that we need to make sure that when we're writing guidelines, we're either using many different methods so that we can cross-reference and use them across centers. And then to the second question, DDX41. So my practice is if a parent has an affected abnormality, then we screen the child donor for that before utilizing that donor or sibling or whoever, or if they need to go to transplant urgently and they have an unrelated donor, then just opt for an unrelated donor. I do think it's getting to be more and more complex, though, because I've had several patients recently who've acquired a hereditary gene from the unrelated donor. several, and then you have to notify the NMDP, and then you have to notify them that they have this new risk for developing a heme malignancy that they didn't have before, and not necessarily CHIP, but like an ATM mutation or DDX41 that they've had from an unrelated donor that was never screened. And so I think with our increasing knowledge about the risk factors associated with leukemia, we're gonna have to change how we screen donors. That being said, what I tell patients now is like there's some studies that CHIP in donors is actually associated with better outcomes, maybe because they're controlling the chip with their immune system and therefore not letting it outgrow, and so therefore some anti-leukemia properties of a donor having chip, but that wouldn't necessarily be the same with a hereditary predisposition to cancer.
Steve, anything to add?
Not much to add on the DSA. I mean, the retrospective studies that we've done have mainly been based on Luminex because of the limitations of the samples that are available for testing. So that's one. So I think that's been addressed. And then the issue of screening donors, yes, obviously you'd want to screen family members when there's hereditary mutations that could be potentially passed on through the transplant. As far as screening unrelated donors, the WMDA has sort of made I believe, kind of come out with a position statement on that so far, that it's not necessarily recommended, as well as some other studies that have come out of the Farber that Coleman Lindsley and Chris Gibson have led as far as the transfer of chip and the implications that may have in that setting. So.
Thank you. Second question.
Hi there, Roger Horton, Anti-Nolan. Just to your point, Leland, do you feel there's a role for cord blood banks as well as the registries in helping with the selection of high-quality grafts? Because I guess it's not just the search and selection. We're releasing these products. There's a role, I think, for cord banks as well, maybe in ensuring that we know we're releasing cords for the right dose. And further, is there anything that we could do to actually work with transplant centres to help their staff stay trained on thawing, infusion, other things like that can also be blockers?
I didn't get most of that.
If we can help with the cord blood selection, right?
If cord blood banks can help with the selection. And you're from Anthony Nolan?
Correct.
Okay, so you guys have a practice that I think is very much different than the practice in the United States, and something that we can hopefully adopt as an kind of a excellent practice. Currently, there's nothing that would suggest that the bank would reach out directly to the transplant physician and advocate for a different graft source or advocate for a higher cell content or a better HLA match. There's nothing like that here. But I think that's maybe where we need to go.
And I can make another comment. I know that I'm not going to make Juliette very happy with this comment, but so in Seattle, we were doing about 95% of our cord blood transplant were double cord blood transplant, and now we're down to 70%. That means that we do 30% of single cord blood transplant. I had a colleague from Japan, Dr. Watanabe, who has actually looked at the comparison between double and single in Seattle, and we don't see any difference. When you choose a good unit, it's a good unit that leads to very good outcomes. So that's something that as a field we need to think about it, because we know that the double the expense for a graft, and maybe we don't need it. And I think Juliette was distracted, so it's good.
I think you should talk about what you. I mean, I know this. You guys do a great job in that quality piece of it and helping to educate the transplant. Am I correct? You guys have a whole program.
Yeah, that's great.
And I think you've shown that really improves the handling.
Yeah, I guess the first step of it was just ensuring that we stopped doing suboptimal releases. So we worked closer with the registry to say, well, hang on, this is going to the US. We should be looking at 2.5 times 10 to the 7 per kilo. This is only 1.5, 1.6. Would you like us to find you an alternative? It's an easy question.
And it's a great example, of how to improve quality. So I really just want to applaud all of the speakers there. This was a fantastic start to the conference. All of you have given me hope, and I feel like, you're speaking to people. I hope that everyone here really listens to what all of you are saying. Leland, fantastic job on the quality piece of cord bloods. And I also hope that everyone here starts to engage in conversations around sourcing of cellular material for other products like you talk. So this is not really a question. I just really wanted to applaud all of you. What a fantastic session.
Yeah.
Thank
and
you,
I,
Colleen.
and I would say amen to that, so that we can stay with Dante. But so that was a fantastic start. We're perfect in time. Thank you so much, all of you. That was outstanding.
Thank you. Yeah, good job, Brooke.